you have muscle outside. So it's called an in and out mechanism. The in mechanism, which is this one, keeps the focus inward, whereas this one keeps the focus outward. And both of these are powerful. And you as thoracic surgeons make holes, cut across this, disrupt this to get to the lung. And you need to put it back, and that you need to understand. The lesser the disruption, the better the outcome. Okay? Right. So as I said, never cut below the lung. If you want to really understand how a chest moves, I hope this video plays. How do I play the video? My finger. I can't get my cursor here. I should take this off. So if you look at this motion, the whole chest moves as an integrated mechanism. Right? So you have movement of the sternum, but nobody notices the movement of the spine. If you move this rib moves. So it's like an integrated motion. So disruption to one rib can disrupt the rib movement on the opposite side, and also on the same side above and below it. That is why people talk about fixing 3 ribs. If you don't fix that ribs, you lose that part of the chest wall motion. So that thing is very key. And also remember, the most important muscle in your respiration is the diaphragm. And it is the single most muscle, I think, which makes you a thoracic surgeon. Otherwise, you will go into the abdomen and become an abdominal surgeon, right? Not a good idea. Okay? We can be friendly, but we can't go there. The diaphragm is a sheet of muscle which has got 3 parts: you all know, central tendon, muscular portion, reflective portion. So the next video will show you exactly how it works, because you will see it moves again in a different way. If you need to understand the mechanics of motion, you see that the whole diaphragm moves. So when you're talking of chest wall reconstruction, diaphragm is an important part of it. If you cut the diaphragm in one area, it will affect the diaphragm on the opposite side, because the diaphragm is a single sheet of muscle with 3 holes in it to allow the aorta, the esophagus, and the vena cava to go through. So remember, you cannot say I'm doing a diaphragmatic resection and reconstruction of the left side or the right side. For terminology, you can use it, but in reality, you're fixing a single sheet of diaphragmatic muscle. And that is the most key thing you need to understand. This also impacts your fracture fixation or your chest wall reconstruction, because the reflective portion of the diaphragm goes up all the way up to the level of the teeth wall. So you cut anywhere, all these things pull down or up is reflected in your motion. So this is an important piece of muscle which we don't pay a lot of attention to as thoracic surgeons. We are all worried about the phrenic nerve, sure, but you should understand why this muscle is so important in your life. Because if this doesn't move well, your patient doesn't breathe well, stasis, pneumonia, blah, blah. Okay? Right, let's move on. I know I'm going to sound like a Synthi salesman, but I am not, okay? I think I will play this video later, but I think we should basically understand what they have done and created is to help you to have pre-contoured plates, meaning McDonald's. Yeah? Free, fast, deadly. Definitely not free, not cheap, but fast food. Definitely immediately available. and is ready-made. You don't need to put in a lot of effort. There are plates for the right side, there are plates for the left side, and there are different types of plates. I think the first speaker talked about intramedullary nailing. So this is one of the things which I purposely put it up. I'm not a big fan of this, because I personally feel it should be put in by experienced surgeons. So when you are beginning in your career in plating, I think you should just start with plates. Don't start with plates. Okay? So there are two types. One is plating for chest wall reconstruction, if you resect ribs, and the other one is when you have a flared chest. So this is how I position for standard thoracotomy. This is how I do my flared chest fixation, because I can rotate the table and do the left and the right side together at the same point in time. Okay? So once you get through all this, the skin and everything, and you see the fractured rib. So once you see a fractured rib, you do not need to take off the periosteum. Number one. In a fracture for trauma, you do not need to take off the periosteum. Okay? And always choose a longer plate, then you can shorten it if you want. Don't choose a short, cut it short and then you cannot grow it long. Okay, it doesn't work. Yeah. So choose. You have enough instruments in the set, which I will explain to you in the afternoon, to guide you as to how to pull it up and how to approximate. But you do understand. The edges of them are blunt, but the tips are sharp. So when you hold, make sure that you do not injure the neurovascular bundle at the lower part of them. You can cause neurocracks. And what is to go around the rib. Now this is called a molder. Okay? All beginners must learn how to use this. We will teach you in the afternoon. You take this, you mold it on a plate, and then you start setting. This is how you learn. This is your beginning. Okay? At this stage, you're a carpenter. You're not become a gardener yet. Okay? So you start with this. This is what you're going to learn. Because the molding is important, because it's three-dimensional. There are 3 axis movements to the rib. Up, down, sideways, and torsion. I will explain in my video next. Morrow, use 3 screws on either side of the last piece of fracture. If there is a flail segment, that means there are 2 fractures in the same rib. There should be 3 screws beyond the last fracture. That you need to understand. Okay? Alright? So now, yeah, all these things like don't notch, don't scratch the plate, all that happens. Okay? It will happen to you when you're beginning. Don't worry too much about it, but don't bend it too much. There's something called metal fatigue. If you keep bending and unbending it, then there can be an aggressive advanced metal failure that you need to understand. So please don't keep bending and unbending it. Okay? Now this holds very well, as you can see. So this was previously shown. So this is your guide. I use that. So this one at the beginning of your, for the first 20-25 cases, I think you should use this. Okay? And after that, as you get experience, then you'll probably donate it. Use water, definitely heats up. It's a machine, it's a drill. Okay, it's a, you know all the mechanisms. So so this is how you measure the screw. The depth of the screw is shown here. The depth gauge will show. Usually it's about 10. For the lower, it's 6, 7, 8. It can go up to 12. Okay, and then we have moved away from other types of screws. We only use bicortical locking screws. And I think the theory behind that was already explained in the morning. Okay, very nicely. In fact, I thought that was very interesting. So if you do that, you know that you've got both the tables. That's point number 1, and you've also distracted the fracture towards each other, which helps in the bone growth. Okay, and you have a lot of colors in these plates and everything. Okay, let me move it along a little bit. Okay, so this is going to explain. Yeah. As I said, this is very key. Removal of the periosteum in traumatic patients is not good. I think it gives you extra traction and also maintains the vascularity of the rib a bit better. Okay? I prefer not to do diathermy work on the lower body. I prefer to cut. Because if it bleeds, it's okay. You can see the bleeding. Do not burn. Monopolar has got a lot of lateral damage. If you're using a bipolar instrument, it is okay. But if you're using monopolar cautery, as surgeons, you need to understand it has got a lot of collateral damage. So if you burn somewhere, you can have a damage elsewhere. So watch out for that. So the classical case of a distracted rib, you use that to pull the ribs into position like that. Okay? And then once it comes into position, you will watch it. And then it is running a bit slow. Okay, right, there you go. Right. So this is another technique to put the iron nail in. As I said, I'm not a big fan of it. Okay, so I'm going to skip that part. Right, but I do tell you, it's very useful in posterior fractures, quite closer to the spine, where you don't have place to put the whole weight. So only in those places I will use the iron nail. Okay, right. Classical case, I think picture is already shown. You have simple fracture, and then you go and fix it. Okay, that's how it looks like. Right. How about holes like this? I've only made a cut, but there's a tunnel inside. So this is why I thought we should also talk about the minimally invasive technique. Okay? Everybody seems this. Doctor is telling me that they don't have a knee post here. Thailand is lacking in a knee post. How is that possible? Can we make sure it doesn't happen again? They should get a knee post. I think they're deserving of it, right? Now, why is knee important? It's because you can have female patients who are young, they can have trauma. Cosmesis is also an issue in the present day and age. We need to consider all of that. Okay? So, don't think, she's had a trauma, it's not, cosmesis is not important. No, that's wrong. In the present day and world, we live in a world of social media where cosmesis does count. We don't do thymectomies with the median sternotomy nowadays, right? We try and go through MIS. For what reason we struggle is because we want to deliver. So this is one of the things which we can do. So I can fix a lot of ribs through this little hole. I can use the MIPO technique to fix 1, 2, 3 ribs. Okay? And then you see fractures like here as well. For that, I can use the technique of retracting the muscle and tunneling thick plates and making tiny cuts of 3 millimeter to 5 millimeter to deliver the screws in that area, which I will show, the video will show right now. So the MIPO set is a right angle drill and a right angle screw. It is actually quite fun to use. It's got a motorized version and a manual version. Okay, and I think that's how it works. It is a very good tool, I find, especially when the access to the posterior segment of the rib is limited. Okay, so this is a set I think you should all have. Okay, and you should all learn and use. Are we demoing it today? Are we doing it today? Do we have a MIPO set here for demo? Not yet? Not yet. Okay. So we'll just do the video, but I think we should have a demo set. So as you can see here, if you have a fracture, which is like that, now we already used the MIPO to fix that. Now these things you can just fix by an open. But I have to open all the way there to do that. So no need to do that. You tunnel the rib here, and that's done. So you fix this part, your 3 screws here, and then you can make that, you see that? You make cuts there and fix those with the screws. So you're done. I will, what else do I have? Okay, this is a 2.5 minute video. So I'm going to play this and I'm going to let you just watch it. We just did this about last week, just to explain here. You see the rib, it has got many angles. Okay? It is curved, it is twisted, and introverted. So it has got 3 angles. So this is a golden plate, which is about 30 cm long, which is free-ended, meaning you can use it for very long fixation. So how do you start? Put the middle point in the middle rib. Okay? Then you start by in-plate bending. You see it's written on top, in-plate bending. Keep that there and do the in-plate bending first. So you get the in-plate part first. Always in-plate bending first. Remember that. Okay? That'll be the first step you do. Okay? So this becomes easier. You do it 2 or 3 times, then you'll all become experts. Okay? And then the second one is the outplane bending. So you will see the next one is the outplane bending. So expensive. As I said, you cannot keep leaking, bending and unbending them because you will cause metal fretting. Okay? Take your time and then do this. Each plate contouring should take about 5 minutes. Okay? And I'm not saying it's by experience. Even for the beginners, it will take only 5 minutes per plate. Okay? So now you do the out plane contouring and then put it on the rib and double check it. Then, what comes next is your rotational bending. Okay? This is where the torque of the rib comes in, which we never see, but it happens in all the ribs. That is why I think Matrix this design is very good, because you see, you can do that. You do this is called rotational plane bending. So this now will completely match the design of your rib. Okay? So now you align in all 3 axes. Remember that. Start with in plane, out plane, rotational bending. In that order. Then you've gotten this done. Okay? That's it. Now, then you'll put the screws in. I'll show you why I do this and how I do this later. Okay, right. Okay. I'll show you 2 cases before I finish. I know it's time for coffee. I'm standing between you and the coffee. Alright. So this is a simple case. 60-year-old guy, he had a lesion which was expanding. It got bigger and bigger. He reached the size, I know the pictures don't do justice, he reached the size of 10 centimeters. Okay? Quite a big tumor. So we had doubts because it suddenly started to grow. We suspected cancer. So yeah, so that's how the tumor looks like. I am giving a talk on day after tomorrow on chest wall reconstruction, so I will have more details in it. All anterior defects must be fixed. You must understand that. There is no such thing as a small defect or a big defect. Before they used to say anything greater than 5, then it became anything greater than 3. And then people realized, if you go back to my original video where I showed you the movement, that the anterior takes the brunt of it. Any defect in the anterior, fix it. Okay? So that's the tumor. As you can see, I made an extra cut. I cut there. I thought there's no tumor. Then I found there was tumor. I went beyond that and cut it. I know it looks like a tortoise. Okay. Now, this is called spanning reconstruction. I am not able to put back any part of the native bone. So this is called a spanning reconstruction. What do I mean by that? Is that there is a gap. So how do you do your bending and how do you do your rotational bending? So we need to kind of have an idea before operation. So we always ask my radiologist to do a CT 3D reconstruction of the opposite side and match the physics of it on the left side. Remember that. As I said, we are born in pairs. So if you're taking the right 6, 7, 8, match it with the torque rotation on the left 6, 7, 8. Then you get it. So that is what I mean by spanning reconstruction. For all spanning reconstruction, please use the gold plates. Don't use the regular numbered plates. Please use the gold plates. Okay? Post-operative course extubated, went home for the day. So you can understand what that makes a difference. Otherwise, this patient would have lost his mechanics. You have to wait in the hospital till he regains mechanics, and then he goes home after a long time. Okay, by doing this reconstruction, you send him home earlier. And I assure you, this guy had totally no pain. And where did that come from? Because I've cut all the nerves, I've denervated it. I actually realized that after 3 to 4 cases, that why are these patients not really having pain? Then I realized that, yeah, I've denervated them. I thought they would have caused hypersensitivity, but no, these patients are absolutely free. Even their paramedical usage is so less. Okay, last one. So just because Juan asked me to do this, I have to do this. I think it's a very important point. So most of us, if you want to do access to tumors in the neck, large tumors in the upper lobe or in the posterior chest wall, this is called what we do in old-fashioned approach. This is an extended posterior lateral thoracotomy. This is called the short Walson approach. Okay? So this is a standard thoracotomy. Beyond this, is a posterior extension. This is called the shop pose. Why? Because this opens your whole chest like a trapdoor. Okay? Once upon a time, a few years ago, northwest of England, we used to do esophagectomy to left or abdomen. It used to be like a butcher shop. We used to do like 40 cases a month. So at that time, it was fun. Because my experience of this grew from there, because I used to open from here to there. And we could do esophagectomy in like, my boss at least, he could do it in like 2 hours flat. Why? It's because everything is open in front of you. And he had fingers like that on the, I don't know, one hawk or something, you know, he could distract you. So this incision is very useful if you want access to the upper part. And this line I always draw. This is at the 10th. This subcostal here is the junction where the diaphragm heats up. So if you connect this line, so if you cut along this line, I promise you, you can do anything in the chest. Okay? Just a quick example of exposure. This is how it looks like. Okay? I'll tell you why I did it for this case. So now you see what I've cut here is the usual. Lats. I still have split the serratus. I haven't cut it. It's only split. But what I've also done is I've cut open a little bit. A little bit of the trapezius there is nicked. But it's the posterior part which you need to remember. So once you reach the standard thoracoid, it kind of ends there. From here, these are the rhomboids. Open the skin, open the fascia, open the fat. Then open the rhomboids major, then open the minor. Do not go at least 1.5 centimeter more medial than this, because here you will come across what I call the lumbar valley. You will come across all the lumbar veins and arteries, and you will be there the whole day. Leave yourselves a safety margin about 1.5 centimeters. So for that, this line is important. The posterior border of the scapula to the transverse spinous processes. The midpoint is where you should be. Okay? That's kind of there. Yeah? Alright. We'll talk about this. This is for a difficult case of aggressive mesothelioma locally invasive. But that's not what I'm going to talk about. This is the last one. So this is a superior sulcus tumor. He had a large superior sulcus tumor. There you go. Classical pancreas, if you want to call it. I shouldn't use the term anymore. You call it superior sulcus. It's a classical posterior superior sulcus. Okay, that will be anterior. That will be posterior superior sulcus. You already know that the brachial plexus here is involved, and you also know it's quite close to the subclavian. So at some point in time as a surgeon, you know when you're going to go in, you're going to do dissection of the brachial plexus, and you're going to dissect the neck vessels. Keep that in mind. So this guy went for radiation, 60 gray, okay, very good response, yeah. Completed his chemo. I usually do them somewhere what I call the honeymoon period, which is just after 4 weeks, but less than 2 months. Yeah, and he had a very good response. So we went in. You take the tumor out. Why do I do this to take the tumor out? If I was capable of doing this MIS, then I could avoid this. But I think this is for beginners. If you are beginning to do radical surgery, T4 surgery, as a beginner, you will be very happy doing this because you feel confident of yourself. You have control over the vessels which are there. That is your arch of aorta. Those are your ribs, and that is your brachial plexus. So you have good vision. You can get above the tumor. You can sit inside the neck, and you will get good margins. You should understand the difficult part of the superior sulcus is taking the margins off the brachial plexus, right? So you really have to take off from the neural sheath if you don't want a recurrence. Okay? So basically, this approach is for access. Okay? In this case, I can put the ribs back. So I don't need to use spanning plates. I put the ribs back. We call this the rapport technique, which is we take the patient's own rib, we completely decellularize it, prefix it on a plate, and put it back. Interestingly, we found that even though there's a lot of gap, these ribs start to revascularize. And we have PET CT evidence to show that they really revascularize. And the patients have absolutely no pain. because the superior sulcus tumor will be nice. And I also use this if it is under 3, 4, 5. This is called a thermocol. This is an acellular matrix mesh. Because these patients have undergone radiation and all that, 1. 2, this is very infection and radiation resistant. If I feel this patient is going for radiation later, do it. 3, some of the patients complain of a grating sensation. If you put plates below 3, 4, 5 on the posterior part, the scapular nerves. So by putting this, the patients don't have that complaint. This is expensive. Please find a cheaper one in Thailand. I'll come and buy from you. Okay? Yeah. Right. So anyway, this patient did well. So we have some experience with this. I'll put on the papers for you later. Any questions? Thank you.
Excellent talk. Any questions from the floor? I have a question. It's when you do the last test to the new technique, do you see any recurrence from the bone at all? Does it put it back?
Good question. No recurrence because we decellularize it.
จะได้มี
And if you note that I made a comment that we did not put back the second rib because we had some doubts about it. So if you have a doubt about it, if you think, oh, no, it's going through, don't put it back. Okay? You should be very clear on that. But for mesothelioma, I will put it back because I know it's whole.
All right. So thank you very much.